much, Opioid, for this for hosting this event, and thank you, Dr. Lesego, for providing the platform, which is clinical care, the clinical care platform. I really appreciate the invitation, and I'm looking forward to sharing my knowledge with you. Yeah, I'm a pharmacist, but more than that, I am a lifelong learner, and I believe in networking with people, other healthcare professional people, in order for us to stand together and serve the patients as best as we can. So let's start with the presentation. It's a presentation about prescription medicine and opioid abuse, and I am let's see. Oh yeah. I'm the managing director of B-Square Synergy Consultants. You can contact me at the following email address and at my at the following my cell phone number. Will the screen is there? You are. Okay, great stuff. Okay, so now we know where we are. So let's start the presentation. The aim of this webinar will be to provide clinicians currently prescribing controlled substances, and by that we mean, when we're focusing in, that would mean prescription medicines with best practices. In other words, we are going to overlook everything from a person coming in as a customer right through to a prescriber, prescribing of script, and ensuring that the patient uses his or her medicine as best can, and ensuring that patient safety is adhered to in all times. That would also include monitoring patients that come in, for example, opioids, and we'll speak later about opioids, where we were focusing in on codeine. So, or said with best practices for effectively and appropriately treating pain and ultimately improving patient outcomes. And this issue will address prescription opioids, and we will concentrate in on codeine with objectives 4. We've got 4 objectives. The first one is adhering to best practices for prescribing controlled substances. The second objective is to utilize strategies for recognizing prescription opioids and for recognizing signs of misuse and abuse of prescription opioids, promoting best practices for managing chronic pain, and the prescribing authorities will play a big role, as well as pharmacists. And the last learning objective would be apply the techniques for communicating with patients about avoiding or reducing prescription opioids. And that is something that I'm going to play emphasis on, because communication in any area of your working setup or your home setup is very important. And we as healthcare professionals, pharmacists, clinicians, nurses, allied health people, etc., have to communicate with each other as well as to the patient in order for to ensure that the patient gets the right medication and uses it in a safe manner. I am going to the presentation. What we're going to do is we're going to start out very wide and going to speak about overview of medicine abuse and reasons for abuse. Then we will be zooming in on characteristics of addiction and medicine abuse. What are the signs and symptoms? What types of abuse do you get? And I will give you examples of medicine abuse. Here, I just need to tell you that we will be looking at 4 groups of abused medicine, and I'll discuss all of them. but we will be zooming in on opioids with specific focus on codeine. And then lastly, we look at the roles of that customers or clients or patients have, prescribers, prescribing authorities, pharmacists, nurses, and other professionals regarding codeine abuse. Okay, prescription medication abuse and reasons why it's on the rise. Now, a definition of abuse is prescription drug abuse is the use of medication in a way that is not intended by the prescription authorities. Prescription drug abuse includes the following. For example, we'll look at that later. Taking a friend's prescription analgesic, for example, for backache, or to snort up or inject in order to get high. Now, why? What is the reasons behind prescription medical abuse, and why is it on the rise? Well, literature isn't that clear about more drugs being made available, but what they are indicating is that doctors report writing out prescriptions more than ever before. So this is escalating and contributing towards the abuse of prescribed medication. And then clients can also go and get information and outlets for selling these medications, which is obviously illegal. Yeah, we have to, later on in the presentation, we'll look at the code misuse project, and then we can, I'll discuss that later. And then since it is Teen Month, teens, for example, if they are drug abusers, they take the medicine from their parents' medicine cabinets, either for themselves or friends to use, but they have no idea what medicines they're taking and which ones may cause serious effects when taking, for example, alcohol. And we'll look at we'll look at drug-drug interactions, of which alcohol and central nervous system depressants will have an effect on enhancing the abuse of those medicines. And teens also think, because it's prescribed by a doctor, that these medications are safe. If we give a eagle's view of what we are, if you look at prescription medication overview, most prescription medications have positive and negative effects, and it can also be detrimental to patients. We see this as when with tolerance, that patients build up, and then they don't know where the line is to stop, and that can result in coma or death. Many medicines has the potential to become both physiological and physically addictive. And then availability of these drugs is a common feature that we have. While working in a retail setting, you will get customers coming in, for example, codeine-containing medication, like, for example, and I'm not targeting any specific pharmaceutical company or any pharmaceutical product, but since we are pharmacists and prescribers, we will know what the medication is. For example, Adcodols or Accurate, the constant use of that throughout the day can result in, is a common feature. Addicts believe that drugs are safe because the doctor prescribed them, and that is absolutely not the case, because doctors take age, gender, weight, symptoms of the patients, etc., into account when prescribing these drugs. And there's a lot of things about that, especially pharmacogenomics, that is arising as a research theme when looking at genetic modification of your genes in the environment, in our environment. That would be, for example, in the medicine field. Teens have also not got the training, and that can lead to overdose, abuse, extreme side effects. For example, central nervous system depressants. They don't concentrate well. They lose weight, and by that abuse, they can cause their death due to the abuse of those medications. The use of prescription drugs other than that was what it was indicated for or prescribed is considered as being illegal. So also is obtaining medication through fraud, buying or selling of prescription medicine without a doctor's prescription is also considered illegal. Prescription medication abuse affects not only the patient, but it affects family, friends, and work relationships. And that's an important thing to remember, because later on in the presentation, we will discuss the roles of family members or people that are near to abusers, as well as the role of clinicians, doctors prescribing authorities, and also a very important role of pharmacists in providing this medication to them. And then another fact is finding help for prescription drug addictions before they spiral out of control. And this is an urgent matter because it's contributing negatively towards the medical field and the safety of the patient. Characteristics of addiction or medication abuse. According to the NSDUH, in America, the most common of these prescribed medication that are abused are analgesics and stimulants. Now we're focusing on teens again, because this is a teen month, and the age of the teenagers usually dictates the type of drug use. When they're young, they go for analgesics. When they're older, they go for stimulants. And we'll be discussing stimulant overuse later on, and analgesics where codeine or opioids also play a role. Now, there's 5 characteristics of addiction or use disorder, and they are listed below. It means they have a craving for drug or a reward. It diminishes recognition of significant problems in behavior. In other words, their behavior is not normal. Dysfunctional emotional responses. If you have your central nervous system depressants, you might have slurred speech. Your reaction might be lower. Impairment in behavioral control. There you will see that their behavior is not normal, and they have the inability to consistently abstain of these medications. So yeah, that's a problem, and we can focus in on that later. Now, what is the addictive signs of an abuser? How are you going to look or recognize an abuser? An addict will often seek a prescription medication from one or more doctors. So another term that you can use this for this is pharmacy hopping. Now, I've come, let me say something about medication abusers. That not only includes teens, it includes adults, it includes the elderly, and it includes your friends. And for example, I might be a medication abuser and you won't know that. Or the doctor might be a prescription, medicine abuser. For example, some medical doctors are abused to pethidine. So that encompasses not only the people that come in for prescription drugs, but also abusers can unintentionally lose drugs so that a new prescription can be used. A funny example of that was when sleeping tablets. I had a lady come in for her monthly sleeping tablets, and obviously we dispensed that on her profile. And a couple of days after that, she said that her sleeping tablets are up. So after I inquired about that, she said no, her domestic assistant took the sleeping tablets and put it into the ground where potatoes, potatoes are growing. So obviously I had a problem with that, and I told her that yeah, it's a problem, and the patient, a person that does that should be perpetrated and should be reprimanded about that. Drug addicts also steal medication or doctor's prescription pads for they start buying medicine from distributors illegally, or rather through pharmacies. For example, I had a friend that was addicted to sleeping tablets, and she was pharmacy hopping from one pharmacy to another in order to get her sleeping tablets. She also increased her sleeping tablets per day, and she stole prescription pads to get her sleeping tablets. She's currently in remittance, so she got out of that. Drugs also use higher doses than recommended due to the development of tolerance. And I want to use sleeping tablets there as an example. You can use, for example, let's say Opioid. You use them more than what the doctor prescribed for, and that is a caution, a red light for all involved in that person, because we all care about our people around us. Now, what are the physiological signs of abuse and medication abuse examples? Now, signs of medication abuse often starts when adding alcohol with your medicine. And I've given some physiological signs when using prolonged medication abuse, when abusing prescribed medication over a long time at high doses. You can see discoloration of the skin and the eyes can become yellow, and this could be due to impaired liver function. They can also be irritable, they can isolate themselves, and have other mood disorders. That's common about that. Any notice of these signs is a good reason to talk to the person involved because we care about them. When we look at, I've used examples, opioid abuse, central nervous system suppressants, and stimulant abuse as in examples. And that can range from anything from your opioid abuse or codeine abuse, as we are going to focus on that in our presentation. Can be anything from dizziness, shallow breathing, slurred speech, poor coordination, mood swings, depression or anxiety. Your central nervous system, the suppressants, also poor judgment, slow reflexes, memory problems. Symptoms of stimulant abuse, and we will look at examples of stimulant abuse, can lead to weight loss or lack of appetite, dizziness. You can get headaches, insomnia, high blood pressure because your heart will be beating faster, so your BP will fluctuate irregularly. Or you have an irregular heart rate, etc. What are the causes of addiction? I've given some examples here, and the list is quite exhaustive. So I've tried to focus in on a couple of them for us to understand what the importance of addiction causes are. Many times stress is the primary cause, and that gives it's like a scapegoat for the persons to say, okay, I had a lot of stress, I'm going to drink some alcohol tonight, have my glass of wine, and I'm going to take my sleeping tablets with that. So it gives them the inability to focus in on the problem to reduce stress. Very often amongst teenagers or peer pressure from the teenagers' side, low self-esteem, where they have patients that cannot say, I can't take the medication, but they will be pharmacy hopping instead. It can also be a excuse me, a gateway to trying to cope with emotional difficult times, and it can be used as an scapegoat. Those are some examples. Now, I can't see what the slide is. What we are going to focus in on is classes of which medication are abused. Okay, 4 classes of, okay, we're going to look at classes of some medication which are abused. And we look at 4 classes there. And again, if you think of the tunnel that I showed you in the beginning of the slides, we are going to go start broad, looking at 4 classes of commonly prescribed medication that are abused. And we'll end up looking at opioid abuse with specific focus on codeine. It's also important to know which or what examples of medication contributes towards medication addiction, and we'll look at some physiological effects of abuse of medication. We spoke about that earlier, but I think we'll go into a little more detail in here. There's 4 classes of medication abuse: sedatives, opioid and morphine derivatives, stimulants, and we'll lastly look at antidepressants. Now, sedatives can be anything ranging from benzodiazepines, such as diazepam or prazolam, clonazepam, and it can include barbiturates like phenobarbital. And why are they used? Because they give a calming effect, they reduce the tension, they've got sedative properties, and they alleviate anxiety. When we look at opioids and morphine derivatives, there we can look at codeine, hydrocodone, morphine, oxycodone, oxytocin, and tramadol. And those painkillers have opium-like substances, and they are used for analgesic effects. Stimulants like methylphenidate or lisodexamfetamine increases energy, alertness, but also increases your blood pressure, your pulse, and breathing. So people take, for example, it's common that university students or students at school take methylphenidate before they, when they start preparing for their exams, and that obviously puts them in a high, and you are alert, you've got energy, and you go on. Stimulants also include methylphenidate, for example, that's used for ADD and ADHD. Antidepressants, there's not a lot of literature about the abuse and misuse of antidepressants that I found, so I'm just going to go through this class of medications in not so much detail. Now, antidepressants are used for a psychiatric medicine that's supposed to handle depression or stimulant effect. But like I said, the literature indicates that the abuse is not that frequent. What examples are there? You've got your monoamine oxidase inhibitors, and you've got 2 substrates, monoamine oxidase A, like ephedrine, norepinephrine, and serotonin. And then you've got substrates of monoamine oxidase B, like phenylethylamine, tyramine, etc. You've got your tricyclic antidepressants like amitriptyline, your norepinephrine and dopamine reuptake inhibitors, such as bupropion, which is found in Wellbutrin, and that obviously gets used for its antidepressant effects in combination with other medication. Serotonin and norepinephrine reuptake inhibitors like venlafaxine, commonly known as Venlor, and duloxetine are also examples. Lastly, your serotonin, selective serotonin reuptake inhibitors like fluoxetine are also included into these medications. Like I said, the literature, I've got a study there from Evans and Solomon, and they did an assessment of this kind of misuse, so it's not very common, and henceforth we will not focus on these classes of medication because we don't focus on codeine. Let's look at, take an eagle's view of prescription benzodiazepines addiction. Now, your benzos are the common choice for prescription medication addicts. For example, azepam, Valium, they drink that to sedate them. Long-term effects of the sedative abuse is drowsiness, lack of body control when walking, confusion, judgment impairment, and slow speech or slurred speech. In high enough doses, tranquilizers can cause a coma and even premature death. Prescription stimulant addiction, and we spoke about methylphenidate as an example. They are also a commonly abused drug, as well as it needs to be prescribed. This is Schedule 6 medication, and these medications are used for the treatment of ADD and ADHD, and it can lead to rapid addictions. The abusing effects of prescription stimulants are irritability, insomnia, inability to sit still, increased heart rate, blood pressure, vessel constriction, and an increase in blood glucose levels. You take high enough doses, it can become deadly by increasing body temperatures and causing irregular heartbeat and seizures. So now we can see that abuse of these medications, prescription medications, always or nearly always ends up with seizures, coma, and then premature or ultimate death. And it's our role as custodians of medicine to communicate with these patients, to inform them with information, and from there on strengthening our networks with, for example, nurses, other pharmacists, doctors, etc. Prescription opioid addiction. Opioid kind of drugs are also the most commonly used medicine. And we said we are going to focus in on codeine, hydrocodone, morphine, oxycodone, oxycontin are also examples. Now, these drugs are abused because are used to treat mild to moderate pain, but their abuse effects is depression, impaired respiration, lower blood pressure, and constipation. Because, for example, your codeine products are often leads to constipation. These drugs act as central nervous depressants, and at high doses, we spoke about overdoses of people that can result in death. The addicts also builds up a tolerance, and it's just a matter of time before a real risk of death by overdose takes place. Some statistics regarding codeine use. Codeine-based deaths, according to an Australian source, said that codeine-related deaths have doubled between 2000 since 2000 to 2009. So there's an increase in codeine, for example, their deaths that needs to put spotlights on its use, and also gives opportunity for prescribers, prescribing authorities and pharmacists to play a role in that. I found in the literature also that they use a terminology of diverted medicine, and that's basically it's the same as prescription medication misuse. And there's a table there of commonly diverted drugs that gives you examples of anything from benzodiazepines, antipsychotics, anesthetic drugs, right through to GABA agonists, which are abused medications. Now, guidance for customers or consumers when inquiring about codeine. We are going to focus on three important points, namely who to talk to, what to do when dealing with an abuser, and then prescription medication abuse risk factors. Guidance for consumers inquiring about codeine. Your role as a pharmacist cannot be stressed enough, because you'll be able to help the patient choose from a range of effective drugs that are not necessarily prescribed drugs. If you have a strong or chronic persistent pain, they need to consult the doctor, and they need to know that they have to go and see the doctor. It doesn't help them just keeping on taking something like, for example, codeine products. Because if you think that you are unable to manage without codeine, go and see your doctor, or pharmacist, or prescribing authority, whichever you please. Now, patients, a common question that comes up is, how can I help a loved one who is addicted to prescription medication? What can I do? And we're looking and we're instilling this knowledge that we have and sharing that with the public in order for them to help identify the abusers, and then from there on we can take that further. So if you think a family member or close friend is abusing drugs, talk to the prescriber. There are a number of drug treatment programs that they can be slotted into. Also talk to the abuser about your concerns so that they know you are aware of the problem, but be prepared for a lot of resistance and denial. And you get that commonly in people. No, I want my codeine medication. No, I don't have a problem, etc. Many patients with addictions must face serious effects before they recognize that they've got a problem, and they need to know that you can stand beside them as they move to beyond their addiction. Some prescription abuse risk factors. We spoke about that earlier, is friends or colleagues' influence, age, genetics, mental health, sorry, their mental health, and their knowledge about prescription medication and profile. And if they know enough about medication, and that goes for prescribing authorities and pharmacists, nurses, etc. If you have a knowledge about a prescription medication that can be used in suicide, you're in a tough spot there, because you as a pharmacist, let's take pharmacists, for example, you will know that the combination of such and such and such medication used with alcohol mixed with benzodiazepines, for example, will result in eventually ending up in suicide or committing suicide. Now we will look about tips that we've got for prescribing authorities when talking about codeine. And those are, for example, the prescribers, the GP specialists, and nurses. And we'll just focus in on our role as pharmacists. So let's see what is important for the prescribing authorities. Number one, they need to know what their role is. In other words, they know where their limits are and when to refer the patients, as well as what prescribing trends there are and what is the correct drug that can be prescribed for a specific illness. What are questions that they can ask to patients? And then lastly, give some guidelines for the treatment of opioid / codeine abuse. Okay, let's look at them in more detail. So as a health professional with prescribing authority, you may see more people requesting codeine for pain management. This is an Australian source. So we are still busy with codeine programs for them to become prescription-only medications. So the part of prescription-only medications on the 1st of February 2018 applies for Australians, not for South Africans, but I've made a screenshot here just to show you how important it is. First of all, develop your practice policies for prescribing medications for pain. Okay, know how to manage pain without reliance on opioids. Know when to refer to an allied health professional for other therapies. For example, go to a pain specialist or a clinic for assessment and management and or drug and alcohol services. Now, what is your role? First of all, and what is your role in speaking to patients or querying prescription drug medication abusers? First of all, you discuss alternative pain medications, which evidence suggests are more effective, and this can include pharmacological and non-pharmacological interventions. Okay. Second of all, you speak to your patients and explain the risks associated with codeine-based products, such as dependence and tolerance, and eventually addiction. So the patients need to be informed about the use of the medication that is prescribed and that there is a tendency for abuse, so that the prescribers will not keep on having a prescription trend of, for example, giving tramadol to patients that got back operations, etc. First, and then thirdly, to develop a treatment plan with patients who appear to be experiencing chronic pain or dependency issues. So your role could then be, for example, to say, I see that your prescription, you've got a lot of prescriptions that I've given you for for any of those four classes of drugs that we spoke about, and then to decide on a plan that both the patients and the prescribing authorities would like to take a journey together. Taking alternative options with your patients, and this is very important, is talking to your patient. We spoke about the importance of communication within a relationship, And here we are speaking about the relationship of prescribers and patients. Here are some questions that you can ask. Do you know what caused the pain? How often do you use this medication? What is the longest time you've gone without taking them? How long have you had the pain for? How much do you take? Do you feel sick when you try to stop them? And can you describe what is going on with you? Here's an example that I gave of suggested talking points for a patient coming in who wants his or her codeine. And they might come in and say, I have used codeine for a long time and it works well. When I don't use it, I have headaches, body aches and diarrhea. And they'll say, codeine is the only thing that works for me. I want my medicine. Now, this slide can be shared for all prescribing authorities and pharmacists. So I've from an internet source of Australia, and we'll speak later about this organization and this website's usefulness. But sample responses could be, for example, I'm concerned about your use of this medication and your health. A request like this can sometimes be a sign of dependence on the medicine. How much are you taking? Or you could say, I'm concerned that providing ongoing medicine is not good for your overall health. I suggest that you trial a graduated withdrawal program, or can I refer you to a specialist? So that's also knowing your boundaries. As a prescriber, to know how to set boundaries on not always giving the patients what they want. Also from the patient side to be informed about the serious side effects that codeine, for example, can have. Treatment or management of opioids, and I am just going through this very fast. Practitioners should offer in and outpatient substance use disorder treatments, not only for inpatients, but also for outpatients. The short-term use of new opioid drugs does not necessarily provide long-term benefits. So again, you need to look at how you are going to prescribe your medication, for how long, and what is the maximum period before a patient can go into the phase of addiction. Regulations should be limiting the prescription of opioids, and we see that this is on the increased side, and that needs to be incorporated with laws. Patients with opioid withdrawal, the treatment of that I've indicated there. Buprenorphine can be initiated for effective therapy in a medically supervised opioid withdrawal step. And methadone is also used. But in opioid overdose, naloxone is used, and that's to reverse the effects of respiratory depression and adequate IV fluid, and also to repeat naloxone dose when indicated. Now we are looking at what our roles of a pharmacist is when talking about codeine. Some questions, we're focusing on three areas. First of all, some questions to ask the patient, warnings that you can issue and that you can see when using prescription medication, and then complications when abusing codeine. And that's where the patient and the pharmacist's relationship comes in very clearly, and gives you the opportunity to discuss the medication abuse and the side effects and the possibility of abusing these drugs with long-term use. Now, there's the tips about talking about codeine, for example, is nearly the same as what we described in tips for talking about codeine guidelines for prescribers. So if we can quickly go through that, discuss alternative chronic medication, encourage the patient, speak to your patients about the risks, such as dependence and addiction, discuss alternative options with your patient, try and get them off codeine containing products and put them on something that hasn't got addiction potential, such as opioid /codeine preparations. There's also some questions, sample questions I have here. Do you know what caused the pain? How long have you had the pain? How often do you use the medication, and how much do you take? That's very important. That's very important to ask those questions for your patients. That also instills the importance of having a close or intimate relationship between you as a pharmacist and your patient, and ultimately ensuring that your patient is gaining the most, getting the most effective and safe medication drug regimens to ensure that they are safe when taking these medications, and also for you to monitor the use of for example, for codeine. We'll speak about the code misuse initiative later on. Okay, so prevention of misuse of prescription medication. Some examples of prevention of prescribed medication abuse is, first of all, talk to the patient about the dangers of prescription medication abuse, and do that when you first encounter the patient. Assure them that you as a custodian of medicine and they, the patients or the clients, customers, need to be aware of, they need to be on the same foot as what you are when taking prescription medication for the first time. Also, I mentioned that abusing prescription medications sometimes have the same effect than illicit medication use. For patients that, for teenagers, for example, we looked at that they can sometimes steal valuables as a means of getting money to buy these illicit drugs. So keep your drugs, prescription drugs, locked away. I know this may sound being paranoid, but unfortunately that's the reality that we must face. That happens. Also lock your valuables away, because the drug abusers seeks, like I said, valuables to sell to get their fixes, and they ultimately will do anything possible. For example, I had a client coming in every single, I don't know if she came in every single month or every single week, but over when I locumed, she would come in and say she wants her sleeping tablets. Okay, I saw that on her profile on the computer that she gets her 10 prescription, 10 sleeping tablets, and she says that she's got social problems at home as an excuse. So in addition to that, she has a valid prescription for other tranquilizers that she can help, but she says that doesn't help her. So what do you as a pharmacist do in a situation like that? If you don't give the medicine to her, she's going to another pharmacy. And every time when she came in and presented herself to me to want to get her 10 Ivodel tablets, she would say, please, could I get them? First of all, I said, I can't give them to you, I haven't got a prescription. Then she started to become emotional. And I said, okay, the maximum dose of Ivodel should not exceed 2 per tablet. When are you going to see the prescriber to get a prescription? No, she'll do it on Monday. Okay, that never happened. In reality, that never happened. Her drug-seeking behavior became so apparent that when we stopped the car and to get into the pharmacy, we would see her doing her rounds up and down in the alley, and then she would hide behind a pillar for us not to see her. So this happens. It can happen, and maybe has happened to all of us, to be abusing some kind of medication at some stage. Some tips when communicating about prescription medications and the interactions with other medicines. Now, since the pharmacist, we're speaking about the role of a pharmacist now, in that context, we are, this plays a very important part in the strive to communicate better patient outcomes by discussing interactions with other medication. Now, according to the National Institute on Drug Abuse, they said, and this is documented, never use opioids such as codeine with central nervous system depressants or in combination with the following: alcohol, antihistamines, barbiturates, benzodiazepines, other sleeping medication, or general anesthetics. So, yeah, that I just divulges the importance of the communication between a patient and a medical practitioner, because you can tell them that they have to, if they're going in for operation, they need to speak to the anesthetist about medications that they are taking. Second of all, don't use your central nervous system depressants with medications that also dulls the central nervous system, and these may include alcohol, prescription opioid analgesics, and some over-the-counter cold and allergy medications. When we look at stimulants, and we spoke about that earlier, stimulants and other other substances that affect the nervous system, for example, antidepressants, which is given to the patient by supervision of a doctor, OTC congestants, and some asthma medications. What are the abuse complications? So this is also an important thing to ask your patients. What are the abuse complications? Prescription drug abusers can have dangerous or deadly effects. You need to make that very clear to your patients, especially if they are taking it in combination with the drugs we just discussed. Now, abuse complications, opioids, for example, vomiting, breathing problems, death. Central nervous system depressants, the central nervous system are so suppressed that they exhibit slow heartbeat or slow breathing. If they are stopping or slowing the dose too fast. We spoke about titration of drugs when you, and that gets done by usually by a prescriber, is to, when a patient comes in and says, okay, I've got a problem with prescribed medication abuse, what can I do? Then you can start the treatment to do titration from a high dose to a low dose. Stimulant abuse, we spoke about methylphenidate there. You get high body temperature, irregular heartbeats or arrhythmia, aggression, paranoia, and can also give rise to heart failure and seizures. Now, the abuse is likely to become dependent or addicted, the higher the chance of committing a crime is. Either by being a crime victim because you're so out of it, because, for example, you've taken central nervous system depressants in combination with the other drug classes we spoke about, and then you can become a crime victim by either committing a crime by stealing stuff or being zonked out, or you can be a crime instigator. I just included this slide that you, and I've got the source documented below that. You might want to put this up in your pharmacy, and I'm not going to in detail about that. You can see side effects of codeine, signs of codeine addiction, and this you can tell to your patient when taking what the side effects of this codeine medication is. Sometimes the patients or the clients, when they come in for the Acadols or for the Accurates, they do not want, or Benylin with codeine, they do not want to hear, yes, you've got these side effects, blah, blah, blah. They are coming into the pharmacy, they want the medication as soon as possible to get out very fast as possible. So there's a lot of pressure on you as a pharmacist to communicate these things to them. They can, for example, say, I'm buying my Acadols, I'm getting them every month, I am not abusing them, I want my medication, give it to me. And that's not a nice situation to be in as a pharmacist or a prescriber, because you need to be a good custodian of medicine. This is also a nice printouts that you can put up in your pharmacy that the patients can read before they have an encounter with you to collect their medications. Now, tips for talking about codeine, guidance for pharmacists. I've included a YouTube movie here. Please take note that this was recorded in the setting of Australia. It's 3 minutes and 49 seconds long. Dr. Lesego, please could you put on the YouTube movie?
Doc, I see we are behind time. I think it might be best maybe to share the link and colleagues can then watch it. I will just share it on the chat. If you can try and maybe push to sum up in the next 2 minutes so that we can have time for discussions, it would be great. Thanks.
Okay, no problem. I'll do the best I can. Look at this YouTube movie. I can also tell you about when we get to the references, we can speak about this later. Now, South Africa, where are we and where are we going? We'll look at SAPRA's role, the role of codeine and codeine, the scheduling of codeine and codeine containing medication, and we'll speak about the Code Misuse Project. We know that the requirement for codeine is a Schedule 2, as stated above, and that SAPRA is considering maybe up-scheduling codeine, but nothing's, there's no final decision yet made. But it would be good if I put stricter limits of the number of tablets an individual can get from a pharmacy, instead of forcing people to get prescriptions for it. Over-the-counter misuse and codeine dependence project, I'm not going to detail about that. The information is all there. The code misuse project was undertaken under 3 countries, and it's important for you as a pharmacist to take note of that. So you can go through this at a later stage. We value our customers and have their best at heart. How are we going to do that? We are going to share knowledge, network, and be good custodians for the healthcare profession. And some taking home messages. First of all, these are suggestions. Become advocates for the Coding Care Initiative and join code misuse. Consider other preventative treatments, and I've given a list there. Clinicians who prescribe opioids should only do that when there is severe pain and discontinue their use as soon as possible. And then there's something I quite like is the creation of social media platforms for discussion of the different medications and abuse, because patients don't have necessarily access to get to a pharmacy or a primary health care clinic as soon as possible. So social media platforms for discussing these options that we've discussed in this presentation can serve them well. In summary, I've got those 6 points that we can focus on, which I think is important for us to know. And I've got that icon or that picture that says we can do this. Okay. United we stand, united we fall. We have got all of us, from prescribing authorities, nurses, GPs, right through to the role of the pharmacist. We all play a role in this matter. References, I just need to say about that. I've got an exhaustive list of references, which will be available on request. You can either ask me or Dr. Lesego about sending or distributing all the references. And then I put a lot of YouTube video links in because it's on-the-go messages and audiovisual content that can be accessed. And then I found this website from the Government of Australia, South African Health, is very, very resourceful. And I would like to encourage all healthcare professionals to log into that or access that link. There is abundant information that you can read. There's resources, there's tips for communication for nurses, midwives, specialists, GPs, pharmacists, medical officers, etc. Go in there and you'll get all the information that you need that you can apply practical. I've got a list of YouTube movies, and we can now open the platform for any questions. Thank you, Dr. Lesego. I'm finished.
Thank you, Dr. Brown. First and foremost, we'd just like to express our appreciation to you for your valuable contribution to our webinar this evening. And thank you to everyone who attended our webinar today as well, to make it such an event which is very successful. So in my capacity as the host, I would like to ask Dr. Walter Ochan, he's present in our midst today, just to give a smaller commentary on the topic that we discussed today. If he can unmute and just have a few words. Dr. Walter Ochan.
Yes, Dr. Ochan, you may unmute.
Am I Anna?
Yes, we can hear you.
All right.
Before Dr. Ochan speaks, he's a palliative care specialist and also has a lot of experience in pain management. So I think he will just share highlights in the topic, which would be very helpful. Thanks, Doc.
Thanks very much, and thanks for putting me on in a tight corner. So yeah, so there are a few tips about codeine. I think Liz mentioned it very well, that once codeine goes in the body, the active metabolite is actually morphine. So sometimes when we're prescribing, we think that the bigger gun is morphine and codeine is the smaller opiate. It's actually labeled as one of the weaker opiates. But once it goes into the body, it goes through the cytochrome P2D6, I think, it turns into morphine, and that's when it becomes effective. And there are rapid, ultra rapid metabolizers, and then there are those who are slow metabolizers. That's why sometimes the other patients get the normal dose of codeine and they don't get any improvement, and another group gets just the ordinary dose of morphine, of codeine, and they get they may die or they go into respiratory depression because they have rapidly metabolized the codeine in the body and turned it into a massive dose of morphine. So every time you make a script of codeine, just tell yourself that you're prescribing morphine to the patient effectively. And then second point about codeine is once pain has been, somebody has been in pain for 3 months and beyond. Other pain physicians label it as 6 months, but from 3 months and above, the pain is chronic. And even if it's nociceptive in nature, using codeine might not help a lot. Yeah? That's the kind of patient you could refer to an orthopedic, to a neurosurgeon, or to someone who deals with that specific organ involved, or to pain clinicians. Not so many around at the moment, but they can help. So the other thing about codeine and other opiates, if there's pain in the head, and you can call that headache, if there's headache and then you prescribe codeine for acute headache, it's okay. Headache that has not lasted for 2 weeks, and as long as the patient is going to just take one course only, that's about 3 to 5 days of codeine combined with other analgesics. But the moment headache has been going on for 3 months and you don't know what the cause is, most of the time the cause of the headache is not going to, the headache is not going to be nociceptive in nature, because codeine works well and other opiates, they work well where the pain is nociceptive. That's where there's been damage or potential damage or risk of damage to tissue. And the tissue that is not neural in nature, as the presenter nicely put it, if it's central nervous in nature, or if it's neural in nature, the peripheral nerve damage, codeine and other opiates won't help you, except for tramadol. It has although it's classified as an opiate, it is more like it works more like amitriptyline and company is described as an SRI. So it's addictive potential, although it's on the list of addictive drugs, it's not as bad as morphine, as codeine when you compare the two weight for weight. And then another thing about codeine and other opiates is if it's for pain in the head or headaches as we call them, initially it relieves pain very well, whether it's acute or chronic. But then 3 things come into play. Addiction, as has been brought forward, and the patients don't agree that they have become dependent physically, they have become dependent psychologically, or they're addicted. And the second one is, which many people underrate or many others don't know, is OIH, that is opiate-induced hyperalgesia. That is pain that is caused by opiates itself. So you'll get surprised. Initially, the codeine kills pain, but repeated use eventually messes up with the receptors in the CNS. So the next dose that somebody takes, instead of reducing pain, causes more pain. And that's why some patients end up with analgesic-induced headaches that are caused by painkillers eventually. And then the other thing that comes along as well is once you don't know what is causing the headache, you actually can produce another type of headache, like patient comes with tension type headache, and then you add on the analgesic-induced headache or the headache that is due to opiate-induced hyperalgesia, pain that goes beyond the pain that we know. Yeah, that is the brief that I can say about the presentation, but all in all, it was a very well presented topic, very well elaborated. Thank you so much.
Thank you.
Thank you, Dr. Ochan. Thank you very much. We have another expert present in our midst, Dr. David Baeva. I hope he can be able to unmute. He is an expert also in substance use and prevention and treatment. So hopefully he can also share some few words with us. Dr. David Baeva, welcome.
Good evening. Can you hear me?
Yes, I can hear you.
Okay. Just to say that, the presentation that you've been given over here, I wanted to give the conditions that we have here in South Africa. Unfortunately, in South Africa, we do have a problem, like, for example, the purple drunk. And the purple drunk is a combination of codeine-containing medication, which is mixed with different types of drinks that are used, commonly the cold drinks that are used. And that is one of our biggest problems. So what I want to just bring to your attention is the fact that we must be very, very aware of the problem that we have in our society, and at all times be conscious of the type of abuse that is taking place, particularly amongst our youth. While we're talking about the situation that we've got at the moment, we must pay particular attention to the youth in particular as our future, and that we need to look after. And the telltale signs that we need to look after are particularly pertinent, but more to the youth than it is for the older people. So that is just my only other comment that I wanted to make. Thank you.
Thank you, Prof.
Thank you very much, Dr. David Baeva. It's just good to see you, my former lecturer many years ago. Don't want to reveal my age. Colleagues, thank you very much for being here. I would also like to present some questions to Dr. Brown and maybe Dr. Ochen and Dr. Baeva. They'll be able to assist in answering the question. The first question is, how can we discourage the use of methylphenidate by students when it comes as disguised for ADHD? That's the first question. Dr. Brown, if you can just be short, please. Thank you very much.
Well, first of all, I'll ask the patient, why do they need it? Second of all, I'd look at the dosage. Third of all, I'd like to know what do they want to use it for, the dosage and dosage regimen they have, and I will look at appropriate number of tablets that are prescribed.
Okay, thank you very much. I hope the person has been answered. The second question is, are practitioners allowed to give placebo if they suspect any drug abuse, or is it ethical to give a patient placebo if you suspect drug abuse? Thank you.
Rafula, are you posing the question to me or to?
To you, to you.
Okay, just repeat the question again, please.
Are practitioners allowed?
Ones. No,
yeah,
I don't think that. I don't think that's ethical to do. I think the way forward is to communicate to that patient in words that he or she understands. If you need to get a translator, get the translator. I've been in situations where people from high up in Africa come down. They can't speak a word of English, and you have to explain to them with signs of how to take the medication. So no, I don't think it's ethical to do that. You have to inform the patients about the side effects of the medication, and I also think that you must look in which stance are you speaking about, or do you have? Are you, and maybe you need to refer that patient to a specialist. So I wouldn't do that. It's lying. Well, the other thing is, we know that sometimes the problem is in the head of the patient, and that they won't be, that if they believe they take, for example, colored pills, tablets like, I'm giving an example that's beyond the scope. Yeah, that looks like Smarties, and you give them Smarties, and you tell them drink it, and they can imagine that they are feeling better.
Thank you, Dr. Brown. The next question is there literature that shows the effects of using excessive number of sleeping tablets every night? I'm sure that you can answer that, but I also think that maybe you can share those literature articles with Dr. Mawela, and he can attach them to the presentation. And then if people subscribe, they can have access to those articles. I'm not sure if I'm correct or not.
No, for sure. I'll share whatever I have. And yeah, it's an important thing that you're speaking about, because people often reserve themselves, apologies, to take sleeping tablets for a variety of conditions. And yeah, it's a commonly misused drug. Yeah, sometimes you know your mind just goes on and on and on and on and on, and you just have to force yourself into sleeping. So that could be a reason why.
Sorry, can I come in for 1 minute, please?
Okay, Dr. Driver.
I don't want to miss the opportunity to deal with the question that you asked earlier about the placebo and giving placebos. And I just want to warn about the harmful effect of doing such a thing, particularly when the person has developed a tolerance already and they're taking high doses, which will very often happen. If you're going to give a placebo, they're going to go through a serious withdrawal, which could be very, very life-threatening as well. So that is the one issue. The other issue is, I think that we must also recognize that we need to understand that these people are abusing substances for a reason. It gives them gratification, it gives them satisfaction, and they are doing it because they are not coping with other problems that they might have in life. And we need to identify what the real reason is as to why they are abusing these substances in the first place. And that is what needs to be addressed. It's not about refusing the medication. It's about understanding what the underlying problem is. Once you've identified what the underlying problem is, show them that there are alternatives, whether it be coping mechanisms that have to be developed or whether it is just the mindset that has to be changed. All of these issues are things that then need to be discussed with the patient. Otherwise, it's of no value whatsoever. Because if you take away codeine, they're going to find something else. And we know, for example, that there are other opiates like loperamide, which is being used for diarrhea. And it's also an opiate, so they're going to move over to that. We can take all of these medications, dump them into the sea, and they will still have a need to satisfy whatever it is that they are abusing substances for, unless we deal with the underlying problem. And that is the most critical problem.
Thank you, Dr. David. The next question, it is on how do we deal with substances abuse if we don't have a computerized database of patients, because they can hop like clinic hop or pharmacy hop. So how do we deal with such a thing? Dr. Brown?
Can I help you?
Sorry, just to repeat the question. The line went down. What did you say was the question?
How do we deal with substance abuse if we don't have a computerized database of patients?
Okay, right. I've got that. You become part of the Code Misuse project, and there's a codeine stopping initiative, well, you can look from there to there is such a software program that can go across all the pharmacies, if I'm not mistaken, where when you enter it in the computer, you can say that this patient identified by this ID number has taken or has been dispensed this or this or this drug, but they will only be identified as by the ID number, so they're anonymous, and then you keep track of the use of codeine containing medication. So yeah, it's networking. And I want to encourage pharmacists to become part of that program.
Okay, can I just take a comment from Dr. David and then close to this question?
What I'm aware of is the fact that SAPRA are looking at the initiation of such a program, which will link all of the information, irrespective of which pharmacy, which dispensing doctor, which clinic, which hospital they've obtained any codeine containing preparation, and it will be linked onto a national database, stored onto a cloud, all confidentiality complied with, using the latest change in registration, which requires a patient to give an ID number in order for them to be able to receive a Schedule II medication. So with all of those initiatives that are taking place at the moment, and the movement that is being adopted at this stage by SAPRA, will, when put into full swing, deal with the particular problem that has been identified. So that is something that will happen in the near future,